Good evening. So great that you can join us tonight. My name is Lydia Dugdale, and I'm the director of the Center for Clinical Medical Ethics at Columbia University. And I'm delighted to be co-sponsoring this event tonight with our friends at Columbia University's Bioethics program. Tonight's speaker is Dr. Homer Venters. And before I introduce him, I would like to introduce my partner in crime, Dr. Barbara Rothschild. Barbara and I have had the joy of working together on complicated and sticky medical, ethical, and bioethical issues. In the fall, we co-hosted a two-part series on ethics and opioids, and you can find those events with our illustrious speakers recorded and on the YouTube channel. But tonight, we are taking a different turn and thinking about the ethics of incarceration. And you can see when you registered our title, Incarceration and Bioethics, Health Challenges That Need Our Attention. And indeed, in light of COVID complicating the situation in our jails and prisons, this is a timely issue for us all to be discussing, and we're delighted that Dr. Venters can be with us. So just a quick reminder, this event is being recorded and live streamed. We'll hear from Dr. Venters after I introduce him for about an hour, and then Barbara and I will take your questions for the remainder of our time, about the last 30 minutes. We invite you to post your question using the Q&A feature, and we also invite you to introduce yourselves and say where you're calling in from tonight, just so we can build a bit of community across this platform. But without any further delay, let me introduce Dr. Homer Venters. Dr. Venters is a physician and epidemiologist who works at the intersection of incarceration, health, and human rights. Most recently, he was appointed to serve on the Biden-Harris COVID-19 Health Equity Task Force. Since April 2020, Dr. Venters has focused on addressing COVID-19 responses in jails, prisons, and immigration detention facilities. He's the former chief medical officer of the New York City Correctional Health Services and author of a book titled Life and Death in Rikers Island, one of our own local jails. Dr. Venters has also worked in the nonprofit sector as the director of programs of Physicians for Human Rights and president of Community-Oriented Correctional Health Service. He's a clinical associate professor of the New York University College of Global Public Health. And we're just so grateful that you can join us tonight amidst a very busy schedule. So I'll turn it over to you now, Dr. Venters. Thank you.
Thank you very much. So thank you to Columbia University for both colleagues in bioethics and medical clinical ethics. I'm just thrilled to be here, be with you all. And I'm eager to talk a little bit about correctional health, some of the ethical challenges that permeate this world, and barriers to care and ethical health access for patients with justice involvement. And I'm also eager to elicit your ideas, pushback, different points of view. I'm eager for a discussion with you all. I've valued for a bit more than a decade my interaction and learning with colleagues at Columbia, with capstone projects and MPH students who have come on to be, some of the most incredible leaders in the field, people that I would follow, to the faculty, to the great support that you provide, and the way you dig into some of these issues. So I really appreciate it. So I thought what I would do is talk a little bit about some of the structural components of healthcare behind bars, talk about a few examples, including COVID, suicide, injuries, talk about a couple of ways to think about the ethical challenges that I see throughout all of these problems that patients face, and then think about some potential solutions together. And again, I love all of the pushback, all of the suggestions and ideas that you have in response. So thanks in advance for frank and open communication, which I know you'll be able to provide. I should start by saying that my opinions here and my recommendations don't reflect those of the Biden-Harris COVID Health Equity Task Force. We are just starting to do that work, and I'm thrilled to be part of it. I'm thrilled to advocate for ethical and equitable representation of people who are in the justice system, whether that includes COVID-19 testing, access to vaccinations, or really one of my primary areas of focus is an honest and rigorous assessment of data. How many people have had this infection and how many people have died? Because I don't think we are anywhere close to understanding that. So with that disclaimer, I'll dive in. So my background is as a correctional health doctor. I came out of my, sorry, I just want to make sure that you all can still hear me. Yes, you can, good. My background is I trained at NYU in a public health fellowship, but before that I was a resident in social medicine, social and general medicine at Montefiore in the South Bronx. And there I had so many patients that taught me about their experience of being incarcerated and how it impacted their health. And it was so compelling to me that I started to see patients across the street at Bronx Defenders, a really fantastic national leader organization in providing not just representation for people in criminal cases, but also thinking expansively about a whole person, about other types of legal challenges. And so as I saw more patients in their offices and learned more about this world, it really was so compelling to me that I haven't really thought about doing anything since. And so I spent a couple of years as a fellow looking at healthcare for people who are detained in immigration proceedings. So the ICE immigration detention system, which is a vast and problematic network of facilities all over the country. And then went on from that to work in the city jails. And there, one of the characteristics that was key to me that I wouldn't have taken the job without was that in New York City, we are fortunate to have an independent health service. That means that the correctional doctors, nurses, psychiatrists, social workers, they work for a health authority. It's part of the city charter. When I started, that health authority was with the Department of Health. And then at some point, we moved it over to Health and Hospitals Corporation or Health and Hospitals, where it sits today. But in any respect, it's an independent health authority. It's not part of the Department of Corrections. That is different than the structure in most places around our country. So we have about 5,000 jails, prisons, and immigration detention centers in the United States. I'm sure most people are aware that that makes us, with the 2 million people who are in those places, the most voracious jailer or imprisoner or carceral society in the world. And those places, those 5,000 jails and prisons and ICE detention and another 2,000 juvenile justice type settings, those places almost all have health services. Well, they all have health services, and they almost all have health services where the health service is reporting to and subordinate to the security service. And what I mean by that is if you find the head doctor, the head nurse, the head psychiatrist, a social worker, their boss is going to be a security person at some point. So the sheriff of a county, we have about 3,000 county jails, that sheriff will then have dominion over the health service. And what we've seen over the last 20 years is a proliferation of private, for-profit healthcare providers, which are really, I think the best way to think of them as staffing companies. I think these are companies that fill the needs of a sheriff or fill the needs of a Department of Correction. And so as you would imagine, the structure is often focused on limiting costs, maybe limiting liability, but certainly having the narrowest approach to scope and the narrowest approach to transparency. And that obviously has profound implications for the health of people who are incarcerated because of our really concerted and nuanced focus to find and incarcerate people with behavioral health problems, people who are poor. What that has resulted in is moving mass migration of people into these places that do have lots and lots of health problems. Now, one of the points I'd like to make, and I'll make this throughout, is that often we hear about incarceration as a process that brings lots of sick people behind bars. I believe that's true. However, one of the things you rarely hear addressed, and certainly it's not measured, is the health risks of incarceration itself. And what I mean by that, and I'll talk about a few of these health risks, is that we think, for instance, around breast cancer or autism, about a two-hit hypothesis. Often we talk about like genetic predisposition or something going on with the patient, and then we think about an environmental exposure that may potentiate either the progression of disease or the severity of disease, or it may be that you have to have both the environmental and the individual factors to have the disease. In detention places, jails, prisons, immigration detention, people are exposed to profound, deadly health risks on a routine basis. But those health risks are almost never measured. They certainly are not mitigated. And when people have predictable health outcomes, including morbidity and mortality, almost never is the outcome, the health outcome of death or of illness attributed at all, or in part even, to the exposure to the health risks that occurred behind bars. And this is one of the core weaknesses or core failures in how our country has approached rethinking mass incarceration. I think that we have made we've covered a lot of ground in decreasing the number of people who are going into some county jails. Some states have made progress in prisons. But one of the things that still hangs out there as a profound weakness, and it's really a great representation of racism in health, is that we don't actually list out all the ways in which these black boxes hurt people, and then we don't attribute the health outcomes systematically to those health risks. And so what it means is that, we're inevitably attributing the outcomes of death to, or the outcomes of illness, or new disability when people go home. We're attributing that to the individuals, and we're not at least measuring in an aggregate way, being honest about the health risks that they've encountered. And that's primarily people of color, people with behavioral health problems, people who are poor, that we have this incompetent approach to. I'll go through a couple of examples to kind of lay out what I mean by this. So for the last year, as that overly generous introduction mentioned, I've been doing mostly COVID work. So a year ago, I was running a small nonprofit that was focused on correctional health policy. And then in January, February, it really started to become clear that there was going to be just a disaster behind bars with COVID. And so I started to get requests to do inspections, to go into jails and prisons and physically inspect, talk to people, and see what was going on as part of litigation often. And so I started doing that in March or April. And so that's pretty much all I've done for the last year. I've been in about 40 facilities all over the country. And probably 25 of those have been court-ordered COVID inspections, where I'm going in, asking these kind of three basic questions everywhere I go. Is the facility finding and responding to individual cases the way it should? Is the facility doing what it should and can to slow the spread of COVID-19? And is the facility finding and protecting high-risk people? And so there are lots of different technical answers or metrics that I would use in answering those questions. Certainly the most profound and primary tool in these responses is release, is particularly finding and getting high-risk people out of these settings, not just to protect themselves, protect them from death from COVID, but also to help the facility manage. You could imagine, and I think we all could kind of generally understand, that when COVID hits a housing area with 40 bunk beds, and there's a person in each bunk bed, and let's say 15 of those people are high risk. They have health problems, or because of their age, that put them at increased risk of serious illness or death from COVID, that some of those people will likely get very sick and die. And so finding those 15 people, getting them out, and also finding people who are near for prisons, let's say within some period of time of their release, or using some other criteria so that we can get people out, could then get you to the point where you have 15 people or 20 people in that housing area. And it allows for a little bit better attempt at social distancing, maybe in the living space. But there are many, many other measures. But because there's such difficulty in implementing those other measures, and because of the cultural problems with correctional staff and imposing infection control measures, really the first thing I look at and the first thing I think a lot of people think about is release, because it helps with the COVID response. It also helps with all the other things that have to happen. One of the things about COVID that I would want to point out for this discussion is that we don't really know how many people have been infected with COVID behind bars, and we don't know how many people have died. We have some data. The Marshall Project's been doing a great job tracking prison deaths. And so, we're at about, I think, 2,500 deaths documented in prison settings. Jail settings, we know less about, and we don't really have that data aggregated. As I mentioned, we have about 3,000 county jails. The Federal Bureau of Prisons and ICE and the Marshals have data also that they've reported. But what I would say about all of the data that we have is that it's poor. And it's poor, and I think that we actually had a really important example here in New York City with the Board of Correction report getting out. I believe it was a Board of Correction report. But, in many of the places I go, as I look into all of the deaths and all of the hospitalizations during the time that COVID was running through the facility, what I find is that there are many cases of COVID that were never reported, people who were never tested, or they were tested far, weeks or months after they had COVID. So they don't show up as cases. And then there are also people who are hospitalized and people who die, whose death is not recorded as a COVID death. And because the health systems in the jails may not have a process whereby they find out what happened to the person after they died, and there is not involvement, really good involvement of local and state departments of health and the CDC generally in correctional healthcare, there aren't really any safety measures or redundancies to make sure that we don't miss people. And so what I find, at least when I look into deaths, is that there are quite a few COVID deaths that are incorrectly labeled as non-COVID. And so I think we just don't know. And that lack of data hurts us because we have some research reports that have identified that, between a rate of infection of between 2 and 5 times higher behind bars than in local communities. But I think that's probably a vast, vast undercount. There's a lot more about COVID that I could mention, but I think that the thing right now that is on everybody's mind is access to vaccines. And so some states or correctional settings are way ahead. I think in California, I believe I've seen that about 40% of the state prison population, people in the prison, have been vaccinated, which puts them ahead of most places. There are states that have just barely started. There are, I think, probably some states that haven't started at all. And that all of that really accrues to the weakness of the governors in these states and really what is purely political sensitivity and bias against people who are incarcerated. And so it runs counter. These are congregate settings, obviously. The need for the vaccines is apparent to anybody who thinks about the COVID response, but because I would say more jails have made progress than state prison systems, and the state prison systems, really that responsibility or failure does roll up to these governors. But I'm happy to come back to COVID later. I wanted to talk a little bit about a couple of other clinical scenarios behind bars and talk about how it presents ethical problems or constructs for health staff, and also obviously the patients feel the brunt of this. So the first one is suicide. As you all may know, suicide is the leading cause of death in American jails, off and on. I think that there are some years it hasn't been, but the last several years that we have data for, it has been. And this is really incredible. We have 3,000 places in this country where people go while they're awaiting trial. So they've just been arrested, or they may go there and then be sentenced to a short period of time, like less than a year. But these county jails, these local jails, have incredible rates of suicide. And the most common response when somebody is in a mental health crisis in a jail is to lock them in a cell by themselves. And this practice, and this practice wouldn't be called by the jail solitary confinement. Solitary confinement, while it's a term used by most of us, even the jails and prisons have other terms like administrative segregation or punitive segregation, but they wouldn't even call this the locking up of a person with a mental health crisis in a cell. They wouldn't call it punitive seg or administrative segregation. They'd actually have a health-related name for it, like mental health watch or suicide watch. And the idea would be that when a person attempts to harm themselves or says, I can't go on, I'm going to hurt myself, or if they're in distress, psychological distress, or seen to be a psychological distress, the response is they'd have all their clothes taken away. They'd be put often naked into a very thick fabric suit. It's not even a suit, it's a smock, a suicide smock. It's probably like the apron you would wear in the radiology context, but without the lead. And they'd have all their stuff taken away, all their letters, all their photos, everything. And then they'd be put in a cell. And then an officer often would sit outside this cell and look through this little vision panel and watch them for 24 hours a day. And that's the response to the person who is so desperate and is so lost hope that they're thinking of hurting themselves or taking their lives. And then 2 or 3 times a day, a mental health person would come by and ask them a series of questions. And the questions are formulaic. They have to do with, are you going to kill yourself? Are you going to hurt yourself? Do you still have a plan? And this approach is taken almost uniformly across the United States in jails and in prisons when people have a mental health crisis. This response then also is extra toxic because many people coming into jail may actually be in the middle of a crisis that involves more than just a mental health problem. They may be having acute intoxication, or they may be going through withdrawal, and so from a substance. So that mixture of events actually drives incredibly high rates of jail-based suicides in the first week of admission, because people who are in withdrawal may also be put into a cell just the same way. People who are acutely intoxicated, same thing. And so many of the deaths that I investigate for litigation purposes involve an early death that happened when somebody was locked behind a door. And I mention this not because for a variety of reasons, but because it is a great example of how the health services in these jails and prisons are all wound up in an unethical delivery system and really in creating more harm for the person. When I mentioned the risks, the health risks of incarceration, this is a great example. So if we take people with behavioral health problems, crises, I should say, like suicidality, and we respond with an intervention that increases their risk of death but doesn't decrease, and the health staff are part of that, well, then we have completely turned this notion of a correctional health service on its head. And so the health staff who are coming 3 times a day to ask these list of questions until the person finally relents and says, I have no plan, I'll, whatever. They answer the questions the way that they should be answered, but without any real engagement about what's going on. That health system really is part of what may be ultimately the health outcome of suicide. We worked with have worked as an expert with the Department of Justice. And so the Department of Justice paradoxically does, I think, to my mind, the best investigations of health conditions in correctional settings. So because the CMS, the Joint Commission, our state departments of health, and the CDC are pretty much AWOL in assessing the adequacy of care behind bars, some of the best investigations come from civil rights investigations done by the DOJ. And so we recently, a team of us experts, health experts, were part of a case in Massachusetts where we looked at the Department of Correction there and identified that this practice that we're talking about, this locking somebody behind a door and calling it mental health watch, was a common practice, and that we linked it to death, and that the Department of Justice in its findings letter said this is the first time, this is really the reason that I wanted to be part of this case. This is the first time that our Department of Justice said this practice, which you would find all over the place, is a violation of constitutional rights. If somebody with a mental health crisis is locked behind a door and they don't get the care they need, whatever you call it, it's really solitary, and that's a violation of their constitutional rights. But this is the norm, and it's really the norm because we've allowed to develop or devolve this notion that a person in a mental health crisis is a security problem. And so we need to take all their stuff away. We need to lock them behind a door because that's what we do with security problems, or that's what corrections, I should say, how corrections respond. I just want to mention one other clinical scenario. It has to do with injuries. So when I was starting in the city in 2008 or 9, seeing patients, I would see lots and lots of patients with injuries, especially hand fractures, facial fractures, orbital jaw fractures, and lots of trauma to those areas. And so we started to, that's when Tom Farley, I guess Tom Frieden was the boss, and then Tom Farley. But we started to really think carefully about injuries and how do we find out what the injury rate is among our patients. And so as we started to count and characterize and change our electronic medical record so that we could aggregate data around injuries, it became clear to us that our patients faced astronomically high rates of injury, higher than anything reported in the community, and that most of those injuries were around violent incidents. And while most of the violent incidents involved fights with other people who were detained, once we changed our electronic medical record to capture structured variables about intentionality and cause and location, we found that actually quite a few of them were injuries that involved correctional officers. And so we started to categorize the types and severity of injuries that occurred during interactions between our patients and security staff. And this data was incredibly important to finding and then reporting on the problem of brutality in the city jails back in 2011, 12, 13. And that actually led the DOJ to come in and investigate brutality. As we did that, though, it became clear that many of our health providers would not accurately document the injuries that people sustained. So we started to do this, the senior staff ourselves, look for cases where we were worried that this might have happened, namely interactions between our patients and correctional staff, go reevaluate those patients ourselves. And as we reevaluated them, see if we needed to correctly change the diagnosis and change the treatment. And so we would find patients with fractures that had not been identified. We would find patients that either were afraid to tell the provider initially what had happened or had told the provider initially what had happened, and the provider had not recorded that. And that problem of finding the truth of it, what happens in an injury behind bars, is something I found all over the country. In many settings, when I look into injury encounters and then I talk to patients and I look at the severity of the objective findings, it's so true and so consistent that there is often a downgrading of injuries by staff. And even if there isn't a downgrading intentionally, what these systems also rely on is a huge, huge burden of work to upgrade an injury. So when I would put out a message saying this person had a fractured nose, and the first doctor said they didn't have a fractured nose, I could get a Department of Corrections investigator might come and brace me and like kind of interrogate me about why I thought that and why am I smarter than the first doctor and why do I think it's different. Even if that first doctor wanted to simply say, take the results of an x-ray and correctly document that, oh, it looks like there's a fracture here. We didn't know there was a fracture before. The administrative burdens to do that required finding the original piece of paper that the injury was documented on, finding a captain to document it, probably finding another doctor to sign off on it, maybe the medical director. All of these steps that involve a huge amount of work and are clearly designed to keep the truth of the severity of injuries and the frequency of injuries from outside prying eyes. And so these systems, one of the things I want to make sure I underscore is that while it can be easy to think of correctional settings as kind of keystone cops and lots of errors and nobody's paying attention, they're actually quite nuanced and sophisticated. And they're sophisticated in the way they can undermine the independence of providers. They're sophisticated in the way they silence the voice of our patients. And they're very sophisticated in the way they minimize access to care and services for people. Every prison system around the country has a classification system of people coming into the prison system. They go to an intake prison and they're there for maybe a few days, but usually a week or two. One of the things that's happening there is that people are looking at them very closely to figure out what's the lowest level of mental health services we could give you. So about half the people in the New York City jails, when I was working there, that were designated as having serious mental illness under our care. When they went to the state prisons, about half of them lost that designation or they got downgraded somehow. The other thing that's happening is that people are looking very closely to figure out what kind of work can they do? How can we get more labor out of them? And so that is those are sophisticated systems. The system I just referenced about injury encounters and the difficulty upgrading injuries, that's pretty sophisticated. It looks like a lot of paper and just a lot of hassle, but really it's very sophisticated. Another element is when people have a problem, a medical problem, and they file a grievance. There's very arcane systems that require people to fill out lots of pieces of paper, to go through all sorts of grievance processes, and they almost always result in nothing happening. This is, I think we have an appreciation of this kind of arcane flurry of administrative barrier with reporting sexual assaults and sexual abuse, which is a serious problem. But that one problem of reporting sexual abuse, because of the prison rape elimination law, has gotten some attention in terms of like higher level attention to individual reports. Most of the other things that people would report about inadequate care is not really on people aren't thinking about how to reform those processes. All of this, all of these health risks for our patients, all of this pressure on the health staff creates what is, I think, a pretty under-recognized or certainly not discussed problem, which is that of dual loyalty. This ethical concept that our mission to our patients is impacted by working in these correctional settings. And that mission, that obligation to care for them, can be impacted in little ways and big ways. And I often analogize it to infection control because we, for instance, know that there are germs everywhere. Every hospital has germs, every clinic has germs. We don't say this place won't have germs, but we're going to look for them and find them, and we're going to do our best to mitigate how they impact our care. Dual loyalty, to my mind, is quite similar in that as soon as you pick up a stethoscope in a jail or a prison or ICE detention setting, the security service impacts the way you provide care. And it can be small things. It can be people not wanting you to write a phenylbuterol inhaler because that means a front cuff order so that people can get their inhaler. And maybe security doesn't want this person to have a front cuff order, or maybe they don't want them to have a cane or something of that nature. And it can be very large, overt dual loyalty problems. Like, for instance, we have, maybe between 50 and 100,000 people in solitary confinement in this country, in jails and prisons. Most of those people, the path into solitary involves a health person, which is a complete breach of ethics, but it happens. To my mind now, health staff and health services are probably the most important seal of approval for solitary confinement, because there is always a process where somebody is saying this group is okay for solitary and this group isn't. And the people doing that are health professionals, and they are doing it at the behest of the security officials. We have yet to have honest conversations about the true risk of solitary confinement. And so what happens is, instead of being honest about the risk to people, each individual gets either a stamp of approval or for going into solitary, or they get an excuse, essentially, that they should go somewhere else. and health staff are at the core of that. So that's a big, dual loyalty challenge or deficiency. Another one is, as I mentioned, turning a blind eye to abuse, physical abuse, sexual abuse. Those are large dual loyalty problems. But what strikes me is that as we roll out dual loyalty training in the city jails, we had great feedback from our staff that they appreciated the training, that they wanted more of it, which you don't hear from a lot of health staff generally. And so I think it's important to develop an approach to correctional healthcare that involves acknowledging these ethical problems and involves structured training for the staff who do these jobs. Now, that kind of helps me pivot to solutions. I think that there are many barriers, there are many deficiencies. This is a system built, on racial injustice, on racism, mass incarceration. And so health and healthcare is a part of all of these problems. It's certainly tied up in all of these problems. There are big long-term solutions, and there are some proximate solutions too, I believe. One of the things that we have in front of us is right now we have the involvement, maybe fleeting, of the CDC and state departments of health in lots of jails and prisons and even ICE detention settings because of COVID. Because these public health structures, which are pretty much absolved from or cut out of involvement in correctional health, and they're happy for it. I shouldn't say that they've been kept out. They've been happy to stay outside the walls. They're in there to some extent now because they've been since March. They've been giving advice on testing. On the CDC promulgated some guidelines on COVID response at the end of March in 2020. I've been using that as a template when I do my inspections. These institutions, which are our evidence-based health structures, they have been platooned into thinking about, and now about vaccines and vaccination. And so the state and local departments of health and the CDC are there and have had their eyes open to correctional settings in a way that they haven't for many, many years, probably since maybe in some places HIV response, but really I think it goes back to places that had TB outbreaks, like in the 90s, in the city jails, for instance. And so we have to figure out how to leverage, and we can figure out how to leverage these institutions to stay there and to look beyond what is just simply, a COVID response. First, they should be figuring out, is the adequate COVID response happening, which I think probably nobody's looking at. But then beyond that, what are some other areas of health that we think about in the community that these institutions can start with? A great example is, I mentioned injuries, traumatic brain injury. The incidence of TBI in the New York City jails eclipsed anything that we could find reported anywhere else. We started to look not just at prevalence of people coming in to the jails, screening when people got there, but we also looked at incidents, new blows to the head people sustained. And this problem of TBI, if you went to the CDC website tonight, you would find a lot on there about youth sports, about maybe motor vehicle accidents, some other areas. You wouldn't really find the plight of incarcerated people or justice-involved people anywhere in their multi-million-dollar commitment to this clinical problem, traumatic brain injury. But it has a profound effect. We have no idea how profound this effect is for people returning home with new disability, the long-term impacts of TBI and CTE, not to mention the short-term impact of trying to adhere to the zillion swords of Damocles that hang over you when you go home with community supervision, you have parole or probation or all these things, you're trying to reintegrate with your family. So this is a great example, TBI, of not just racism and health, but how we can actually expand or think beyond COVID in terms of a use case for how to get our evidence-based structures, the CDC and state DOHs, more involved in health of people who have justice involvement. I think that there are just one or two other potential solutions that I'll mention. One is, we've heard a lot about Medicaid. There are these, many of you may know, really since 2015 or 16, we've had there have been these 1115 waivers for Medicaid for a long time, where states can propose to do something different with Medicaid dollars. And so I think that we even put one together at the end of the Obama administration, but to propose the use of some Medicaid funds in some manner for people who are in county jail, maybe to for MAT access, methadone, buprenorphine. And so there is much more vigor and life to this idea, both through a potential bill that's in Congress. I think it's in committee, and then also some of these waivers are still sitting there with CMS. That process, I think, does have promise, because it's true that the resources to provide, because the funding of all these health services has been cut away from federal funding. It means local towns, cities, states are all determining what they're going to spend money on. And so to do more health care, to do better health care, it could potentially cost money. And so I think that there's a great upside there. What I would say is I have a healthy and strong cautionary note, which is that, as I mentioned at the outset, these are not independent health services. The Correctional Health Service of a county jail works for the sheriff. And so if you look right now, there are lots of sheriffs all over the country that have made decisions about who gets MAT, just sticking with this use case, and when they get it, that have nothing to do with evidence-based standards of care. And so my concern is in not shelling out billions of dollars to these security agents to say they can do what they want, and we're going to call it an improvement in healthcare access, because I don't think that'll be true. So I think that the involvement of the community plans is critical, because what we'll find if you went into a jail today, you would find that a couple of things we talk a lot about in Medicaid reimbursement, the environment of care and the rights of beneficiaries, are pretty non-existent in jails and prisons. And so I think we need to think carefully, and I think that the demonstration projects that come out of this will be thorny and give us a lot to think about or to consider. But I'm going to take it back to, I'll end with kind of a smaller frame, which is hospitals. So hospital staff are the ones that take care of patients that come out of jails and prisons. Now, there are many barriers to these patients ever getting to a hospital. As a matter of fact, there's often an outright prohibition on nursing staff who do most of the care, most of the time. These are nurse-driven correctional health services. Often the nurses can't transfer a patient on their own. They have to call a doctor. They have to get approval. There may be extra barriers. Once a patient gets to an ER or an ED, however, or they get to a specialist, there are loads and loads of ethical challenges for the provider who works for that hospital. And there's often very little guidance for the clinicians who find themselves in those ethical quandaries. So imagine you work in the ED. Anybody who's worked in an ED has had an incarcerated patient come in, usually with 2 armed guards. They take up all or half of your emergency department. And then that patient may report things to you like, I haven't gotten my medicines, or I have been beaten up, or I've been sexually abused. Most hospitals do not train their staff on how to respond to these issues. And the lack of autonomy of the patient in that context, with a correctional staff there, not leaving, not going anywhere, creates an almost impossible situation for that provider. By analogy, that happens all the time behind bars too. But for instance, in the city jails, we came up with a system whereby individual providers could report concerns about, let's say, physical abuse of a patient to me or to the senior staff, and then we could launch an investigation outside of the moment, the kind of crucible of that moment. But most doctors and nurses who work in an ER don't have those systems set up. They haven't been trained on how to handle that. And importantly, nobody in the ethics committee of the hospital or the hospital quality committee is tracking these problems. So if you're a hospital, for instance, that sees patients from a local jail, and you have 3 or 4 times in a row had patients who came in a mental health crisis, you cleared them to go to that jail, and then they went into solitary confinement and took their own lives. I think ethically, that hospital, and I don't know about legally, but ethically, that hospital has done those patients a great disservice, because after the first time it happened or the second time it happened, somebody at that hospital had an obligation to say, look, we have this relationship. We send patients back to you who are, we think, somewhat stabilized from a mental health crisis. You put them in the solitary confinement and they get worse and they take their lives. We have to stop that, or something has to change. And it's not just solitary confinement. I think one of the very common things I see is people never get physical therapy. So people who have a CVA, who have a stroke, and they go to an inpatient stroke unit, and on the way out, a young healthy person gets a boatload of on their discharge summary physical therapy written for them to have. They never get any of it. I think most of those hospitals know that's what's going to happen, and if they don't, they should. And so, one of my suggestions in terms of the kind of ethical conundrum for the community-facing providers is to get much more organized with their ethics committees, their quality committees, look at the types of relationships they have with county jails, state DOCs, federal authorities, and think about what standards of care that they understand are supposed to occur for patients, and do they have ample evidence that maybe patients aren't getting that kind of care. True for specialists also. I think that those kind of are some of the main areas I wanted to talk about. I really am eager to get your questions. I see a few questions already loaded up. But I think that I'll finish with patients in correctional settings have really had their voices stripped away. And part of it is this dual loyalty issue where they may not be believed by their own health providers, or they may not be, they may not be believed or listened to. But because people, particularly in county jails, they come in and they leave quickly, there really is not a very competent approach to understanding what their experience with healthcare was, or how that experience changed their engagement with healthcare writ large. And one of the bigger research areas that remains mostly unaddressed is how incarceration damages healthcare engagement. So imagine you were in a jail or a prison or ICE detention setting, and you saw that health staff cleared you or somebody for solitary confinement. Or imagine that you got beat up and the nursing or medical staff either didn't take care of you or they didn't document what really happened to you because security staff told them not to or pressured them not to. Those are profoundly negative experiences that people have routinely in detention settings. 12 million incarcerations a year. Lots and lots of people with these experiences who are going home and who we have all sorts of thoughts around how to engage them with healthcare. And so one of my hopes for community health systems is that they get much more sophisticated about trying to figure out what has happened to people and their health while they're incarcerated. And we have great, my dear friend and colleague, Emily Wong, and others have started these transitions clinics. We have Aaron Fox, a great colleague and leader in this area over at Monty. Columbia has had a great also engagement with people. And so these efforts to kind of like find people as they're coming home and engage with them about what's happened to them is important. But for researchers out there, I think we don't know much about the long-term damage to health engagement that happens because of mass incarceration. And that would be one of the long-term health risks of incarceration, much broader and longer lasting than some of the ones I've been talking about. So I would love to talk, and I see there's some questions in the chat. I could either address those or turn it over to the great moderators who have been so generous both with time and also with putting a lot of thought into this session. So I'll kind of post up there and just stop with a real heartfelt note of thank you for everybody.
Thank you so much for your work and for this talk. I have to say, I have a zillion questions of my own, and I know there are so many in the chat. It's overwhelming, actually, and somewhat disheartening. So I'm glad that you, Emily Wong, my former colleague when I was at Yale, and others are doing this incredible work. I think Barbara's going to kick us off with the first question, and then we'll just kind of toggle back and forth.
Yeah, thank you. When Lydia and I planned this, we have been thinking about vulnerable populations and bioethics, and where is bioethics not focusing its eyes? We certainly do lots of work, and deservedly so, in palliative care, end of life, lots of the assisted reproductive technologies. But we saw, when I went to do more research on issues around the incarcerated, I had a very difficult time in the bioethics literature coming up with much. And so we have a lot of great questions, and we need to give them time. So I'm taking the privilege of asking my question, which is, what could bioethics do, and why aren't we more focused on this? I mean, your talk just now for 15 minutes, I was just like, no, I mean, I was doing this the whole time. So why aren't we there for you? And what could we do as a bioethics community to be looking at this? And I know one of the things you said was that data is missing. And so that seems like a huge problem, but that's not the only thing bioethics relies on to start conversations.
Yeah, I think that, first of all, I don't want to characterize all the jails and prisons to be of one stripe, because there are really, there are places that have really great progressive approaches to healthcare. I think the city has a very sophisticated health system, correctional health system. There are others where I've seen the security service be out in front and trying to do things better. But I think at the end of the day, this is really about power. And it is just inexorable that when we create a jail or a prison, a place of detention, that power dynamic will lead to abuse and neglect. And that the health services that are in that box are going to be part of the abuse and neglect. And the only way we contend with that is by building rigorous structures to find and prevent that from happening. And that requires transparency, and we really just don't have that. So every time I talk about I had a recent talk about dual loyalty, and a person who ran a big state prison system, not the worst, not the best, I don't think, but said, geez, that's horrible that you had to experience that at Rikers. I'm so glad none of our doctors have that problem of dual loyalty. I was like, that's really deep. Imagine somebody said that about washing your hands in germs, right? And I think that's where we're at. And so I think that the power that we need to establish on behalf of our patients, much of it comes with transparency. And so when you see around the country proposals for like an ombudsman or some independent review of deaths or an independent monitoring or some system like that, there's a patchwork of oversight and monitoring organizations around the country, not very many of them. Those groups, I think, could use and benefit from ethics frameworks. Correctional health is almost, off the map when it comes to like this kind of support and engagement. Nancy Dubler just paradoxically reached out to me yesterday about a trying to put together like a talk about medical ethics and correctional health, which is probably the 15th time that's happened in the last, decade. But I think that the ethics community can provide some structure to how we approach ethical issues outside of, in the rest of the community in healthcare, and bring that to bear on correctional health services, but also the monitoring and oversight boards, and really support the idea that it requires transparency. You don't get to just say you're doing the right thing and never have it measured or reported.
Thank you for that. I just want to quickly pause and say that the Columbia medical students have been particularly interested in this question. And when they first came to me, and I'll say the ethics representative from the first year class I know is on this call, Hart Fogel. And when Hart came to me and said, the students want to know more about ethics and incarceration, part of the follow-up to that conversation was also detention centers. And it was jarring to me when you said, I wrote it down, 5,000 jails, prisons, and immigration detention centers, that you put them all in one phrase. I guess I hadn't quite thought of them all being together under that same number. And I was wondering, maybe just to broaden the conversation slightly, if you could talk about distinctions between your work in jails and prisons and what you know or have seen in detention centers. And are there marked differences?
Sure. I think that, they're very different systems. I think that people of the 40 facilities I've gone into in the last year, some of them have been each of those types. I think that immigration detention there are a lot of like unique aspects to it. So in terms of how long people are in these places, it maybe is a little closer to a county jail. Traditionally it was shorter stay. I think that people are coming in also, it depends where they come in. If they're coming in from, being taken off, like arrested or detained off the street. It may look a little bit like a jail admission. On the other hand, the federal government has proliferated these programs to kind of suck people out of county jails and state prisons. So increasingly over the last decade, you have more people coming through like these programs like 287G or Secure Families, where they pull people from one type of incarceration into another. I think that these are deeply problematic systems, and I think that the flavor of problems is different. I think that one of the things I saw in my COVID work in ICE detention settings, and I wrote about this in my reports for the court, involved just the lack of using basic language services for people when they're getting a COVID test, or when somebody would come in and say they screen people for COVID symptoms, and then it would be clear that nobody who speaks their language ever came into that housing area. So it kind of made clear that that wasn't happening. I think that one of the bright spots in of the cases the litigation I've been involved with since April, I think where we've been most effective is in ICE detention, where we've gotten the number of people in ICE detention. I don't say we, I mean the lawyers really do all this work, and the people who are detained are out there advocating for themselves. But the census of the ICE detention system is the lowest it's been, I think, in probably 15 or 20 years. And so one of the really important commitments that I think is being secured from the new administration is to keep it low and to drive it even lower. But the federal judges have been much better about forcing ICE. There's one of the facilities I was at not too long ago, all the high-risk people were ordered released by the judge. It was great. I think that there are some prison settings and a few jails that have done that, but that actually has been a bright spot in the COVID response. But, the jails are chaotic, messy places. They have lots and lots of early admission death driven by overdose, suicide, withdrawal. Prisons, I think, often have different types of medical neglect and abuse. And the overall level of mortality is lower in immigration detention, but much lower in immigration detention. But part of that is because I think people die after they've been deported or removed. And so it's a data problem.
We have a question from Emma Frost about medical students who are interested in pursuing a career in correctional medicine, and what advice you might have for gaining exposure to the field, providing patients with their best care. And she's commenting how most students never get exposed to this area of medicine. And do you have any comments on that?
Yeah, I think the two things I would suggest is one is to find people who are in the field and just latch onto them. I think when like Ross McDonald, who's the doctor, who's the chief medical officer of the New York City jail system now, I think he reached out to me when he was a med student and I was a fellow, or maybe just the deputy medical director. And then when he was a resident in Monty and I had finished, he started coming out and like helping with vaccine drives and doing all sorts of things. And so I think finding leaders, that team out there now is all sorts of like just smarter, more competent, more erudite folks than I ever would be. And there are lots of places have now started to attract mission-driven, patient-focused doctors. And so finding a person that clicks with you and you see they talk about stuff that you care about, that's important. The other is it's really important in picking schools and medical schools and residency programs to ask what their attitude and approach is, because it's a real pain, when you go to a jail, they say weights and gates, but every time you go to a jail or a prison, you're sitting around forever and you never know if you're going to get in. The security processes change every time you go, so it's really inefficient. So it's frustrating for residency directors, and they, without a stated commitment to working in a place like that or learning about it, it's very difficult for residents to do it. And so, I had the great support at Monty. I was able to do my whole public health project in Bronx Defenders, which was great. I got to learn a ton about over the time of my residency. So I think it is really important to look and ask. And if you find a person that, seems to kind of like be doing and saying things you're interested in, latch onto them. And they'll eventually, they're like everybody, they have to keep pestering them.
There were a couple of questions at the beginning of the talk about, I think, some general feeling of outrage. Why aren't the doctors doing more? And you've brought up this question of dual loyalty, and that maybe putting those two questions early on about why the doctors are sort of succumbing to this power of the correctional officers. Putting that together with maybe a question, you said that in New York, the physicians are not under the authority of the government. And I wonder if that makes it a different place to practice. Do physicians feel more freedom, or clinicians feel more freedom to report accurately because there's a little bit of a distinction there?
I hope so. But I think that without formal training and structures to find and root out and mitigate dual loyalty, I think that actually these are forces that could really come to bear negatively on all of us. I just think it's, we, in the book, I talk about an incident where patients were beaten in our clinic, and the COs brought them in, the young kids handcuffed to the gurneys, told all the staff to get the F in the back, and beat them viciously, like blood covered the cabinets. And I got there shortly after, and there were 3 health staff there. And they all told me exactly what happened. And 2 of them said, I'm not going to talk to anybody about what happened because I know I'm going to get retaliated against. The 3rd person was a new employee, a brand new social worker. She's like, sure, that's what happened. This is horrible. She spoke out, and we called my boss. We reported it. But she was one person reporting this. And that beating ended up not going anywhere in terms of being investigated. But she experienced swift retaliation within days. And she ended up leaving the Correctional Health Service. And that happens all over the place. And so, when we would do our dual loyalty trainings, we would do these scenarios, it was a scenario-based training. And we go through 10 scenarios. But, these scenarios, some of them are quite common. It doesn't strike you in the moment that what you're doing isn't going to help your patient. And so I think it's very, this dual loyalty pressure is everywhere. It's not always the huge thing, like run away from the beating. It's often the small thing, like don't talk to this guy, or don't worry about that with this patient. So it's inexorable. It's everywhere. And I think that it's just very hard. I am deeply, deeply critical of health services and health providers when I find these cases, but these are structural problems that are just so much bigger than any doctor. And I would say, besides all these structures, correctional health services need to be led by people who can have an adversarial interaction with the security staff. And that's hard to do because most of these systems, the health service works for the security staff. And so the premium is always on cooperation, and there's a great value to cooperation. And I see in my own career maybe some of the downsides of the adversarial interaction, but these aren't settings or places where the norm is for people to take a tough tack with security, or to do that over and over. And so it's very difficult. I'm not sure it's always solvable, but we could be doing so much more for our patients if we trained all our staff on dual loyalty, if we looked for dual loyalty problems, like doing structured. The publication on this, we looked for structured words in thousands of patient notes to find dual loyalty, like malingering is a great example of a word that we would look for. And so there are things we can do to find and root out this problem. Some of it's individual providers, but mostly I think it's like these are structural failings.
We have a question about the practice of using healthcare staff to act as COs. And when there's shortages in a facility, and this would seem to exacerbate the dual agency problems. Are you aware of this, or is this an issue?
Yeah, I think that the most states and pretty much everywhere, every state has a correctional law. So it lays out what law enforcement people can do and what correctional officers do. So as a technical matter, a health person, a doctor or a nurse can't go do the job of a CO. That would be illegal in every state. However, there are many circumstances in which the health staff do step in and help people. So for example, I think the greatest mentor and boss I've ever had, Mary Bassett, who, when she was Commissioner of Health, really backed us on all of this work. It was just so strong in supporting us and supporting our patients. She and I went to another state once, and we were sent there by the mayor to like see how great it was. And really what we were supposed to see is how great the team of that correctional health was in working with the security service, because we were at odds with the security service. And so it's like a forced field trip. One of the but we got there and it was like a horror movie. We were horrified. We were like, we got to get out of here. This is everything we saw made us more terrified and more horrified. But one of the things we saw was that they were proud of the fact that in certain circumstances, some health staff had been trained to work in the booth and push buttons to open doors and close doors to replace like a correctional health staffer. And so, that was horrifying. Another little bit I will share is that in the the Federal Bureau of Prisons, so the U.S. federal government has about 120, 130 federal prisons around the country, and then probably about 30 private facilities. But when you work in the Bureau of Prisons as a doctor, you go through the same training academy as the security service does. I believe still it's at least the same basic training, and that includes how to shoot a gun. And that is horrifying to me. It's not horrifying to the BOP people. It's just part of their culture. But so I do think there are circumstances that involve technically somebody doing the job of a security person. And, I think it's problematic.
Thank you for that. So when Barbara and I were talking about doing this talk, she had suggested that care is really inadequate. And then I knew I'd read somewhere that actually some conditions receive better treatment in prisons than they would on the outside. And I'm thinking maybe of some types of cancer treatments that then aren't carried through on the outside. But everything you've said to me tonight, to us tonight, makes me think that overall healthcare is just much worse. So there's a question from Amal Jamal. What happens if a prisoner needs regular medical examinations? And I'm just wondering if you could give us a little bit better. But is there anything that's better in prison?
I think, if anybody who's like a correctional health leader listening to this right now would be like upset. They would be like screaming, saying like, we do such a good job and there's so many things that get better. And I wouldn't disagree with that. I think that's the mantra. Like what I guess I've been saying is the like counter veiling point, but the mantra in correctional health is we get these patients, they never get care. The first care they ever got is with us, and we do a great job. And that is true for a lot of patients. A lot of patients, we used to track, for instance, the diabetic patients. We'd see the A1C might go down over time. The blood pressure might be better controlled. Lots of patients get diagnosed, through in prison systems, for cancer screening. They get cancer diagnosed and treated. Probably one of the greatest success stories that's spotty in terms of commitment is treatment of Hep C. Hepatitis C. There are lots of places, jails, fewer jails in some prisons that are, and I would say thanks to litigation, are treating people. So there is good care that happens. I think that my focus is on how is it that even if you find a system that you would say is high functioning, that has a commitment to evidence-based care, I still think that the lack of transparency and attention to dual loyalty means that some patients are going to get worse care. So the patients that are perceived, when I investigated death, which is a pretty common occurrence behind bars, one of the first things I do is just, quickly scan the medical record. And what I often will find, if it's what I would call a jail attributable death, a death where something that happened behind bars really led to or significantly contributed to the death, what I often find is there's a point in time where that patient stopped being treated like a patient. And it'll be like when somebody called them a malingerer, when somebody called them a liar, when somebody took offense at something they did, that health service stopped acting like a health service. And that can happen anywhere. And it does happen all over the place. And so, not that long ago, I was involved in a case where a person had like the cardinal signs of appendicitis. And by day one, belly pain, then belly pain, nausea, diarrhea, vomiting, sweats. But on day 4, the nursing staff actually forced him to sign an AMA, a refusal of treatment, because he wouldn't walk from the cell that he had put into over to the medical clinic. He could not stand up, right? He was obtunded. He was sick. He was in, mortal peril. He died of appendicitis. But what I see and what is so emblematic of the bad outcomes behind bars is that at some point, some of the patients, not all of them, maybe not even most of them, stop being treated like patients by the health service in front of them because they don't like them or because they take offense at something about them. And that switch, when it's flipped, it never goes back.
We have a question from Sarah Bergstresser, and I want to read it and then add on to it just a bit. With the focus on COVID-19 risks and case reporting, can you address the flow between jails, prisons, and other congregate settings, including psychiatric hospitals, wards, shelters for the unhoused, et cetera? And I would add to that, I mean, in today's, the city report from yesterday, and then the New York Times today, the lack of accurate data about COVID in our local community jails and prison system, I'm wondering, and maybe I'm out on a limb here, but could that also be related to their access to vaccine in the public? If it's seen as though there's not much in the prison system or jail, then we don't need the need or the pressure to provide vaccine is going to be less. So just sort of that whole story, if you could comment.
Yeah, I think so. From an operational standpoint, right away in March and April, facilities stopped transfers. And so what that did is it helped shut down really a lot of the nodes along the mass incarceration pipeline. And it was great. Fewer people getting arrested, fewer people going to courts are closed, fewer people going to jails, and then fewer people going to prisons. And what we found is that we could do all that, and there actually wasn't a worsening of public safety. So that's one of the great lessons I think we want to take home from this experience. But then eventually, and so in that, most places didn't get or have access to testing early on. But by the summer, most places had adopted an approach where the BOP calls it, the Bureau of Prisons calls it test in, test out. So when you come in the front door, you're going to be in a new admission quarantine for 14 days, and you'll be tested at the beginning and the end of those 14 days. Similarly, before you get transferred out, either to go home or to go to another facility, you would get tested. Those are all sound approaches that are now fairly standard. I think that we now have a standard of care to vaccinate everybody in correctional settings. And I say standard of care in that I advocate for it. And I can point to a couple of places that are doing it. We're not there yet in almost every place, but I think that the inter-facility transfers, I think was an early point of focus, even by the CDC. I will say, I would think that that probably in some places, there was this kind of like public focus on whether or not how harmful was incarceration and the COVID. But I gotta say, what is really sad is I think in a lot of places people don't care. If I look at the pushback, I have been in some states in the South where nobody's getting vaccinated, and people will say to me privately, it would be political suicide for me to even think about talking publicly about incarcerated people. And these are places where some of these states have just incredibly brutal systems where there's prolific physical, sexual abuse, high rates of death. And so I fear that question about the data could be an element in some places, but it's just how deep this kind of racism and the mass incarceration is. I think that we've kind of convinced or tricked a lot of the nation into thinking that these are people that don't matter. And so I worry about that.
A question that we haven't addressed yet is the legislation that was passed a year before COVID hit, which was supposed to help reform the correctional system. I think it was called the First Step Act. And I was just wondering, in your opinion, have you seen that legislation have a market benefit on the prisons and jails? Or has that all gotten kind of sidelined from COVID?
Well, I think there are people that went home from the First Step Act that wouldn't have gone home. So I think it's important. I think that, there are a lot of states that are still have like incredibly long sentences. Lots of people with life without parole, lots of people in like multi-decade sentences in some states that in other states would be, very short sentences. And so I think that there was a benefit to that. I think that the First Step Act, in theory, also increased funding for programs. Most of those programs are pretty much were shut down during COVID, or if they were starting to be implemented, not much happened with them. So hopefully people can have access to the programs. I think that one of the biggest changes that's really important is access to Pell Grants, people having access to higher education while they're behind bars, because I don't necessarily have a lot of confidence in the general jail or prison programming for rehabilitation. But if people can get something tangible like a degree that they can then go get a job with, I think that's what really is going to help people.
We have a question from Michael Sutcliffe. I'm disturbed by the lack of participation by people who are or were incarcerated in policymaking. How do we move the needle on health and policy literacy and improve representation without tokenizing?
I'll tell you, there are a couple of groups I follow and I support. One of them is Just Leadership USA. So Deanna Hoskins, who runs this national organization, this is a group led by and run by people who are directly impacted. And so Just Leadership USA is always, like when I write an op-ed in The Hill, I often will reference them. Another group, FAM Foundation, which advocates for families of people who are incarcerated. Those two groups, and there are many others, but those two groups for me are my starting point for, and Just Leadership USA has been at the forefront of changing policy in New York City, but also in LA and in other places. It's a national organization. So I think that if you looked at their impact in this space, I think that there are many other groups like them. That happens to be the group that I happen to have kind of thrown my weight behind and as often as I can and try and support. And so there are, depending on what topics or areas or part of the country you're in, there are certainly many other groups, but I would start with them.
That's great. Thank you for those recommendations. There's a question from Vid Raturi about how physicians, or we could say other clinicians, are actually hired into the correctional facilities. Vid refers to one facility that 60% of the physicians hired had previous disciplinary records with the medical board. Is that pretty common in your experience?
I don't know if that is so much common. That one stark metric. I think that it's hard to get people to work in these places. There's no doubt about that. And particularly, we put our prisons out in the middle of nowhere. So finding, for instance, an OB that will go to a women's prison is pretty hard to do. And state DOCs will often say, look, we're offering 2 or 3 times what the community rate is. There's not a single person we can find. I think that we're changing that with this recruitment of mission-driven doctors to come into these places and advocate for their patients. But it has historically been the case that that's true. But remember, I don't think actually it's so much about the individual providers. I think it's the structure. If the structure of the health service is that a staffing company gets hired, like the sheriff puts out an RFP, a proposal, a request for proposals, and then picks the lowest common denominator, the lowest bid, the lowest dollar bid, and is always a for-profit provider, then that staffing company is going to go get some people to fill those chairs. That's a very different model than having people who either have academic training or who have some independence. And so, I think that and I would say that I think many of the people who have been working in these difficult, problematic relationships with security, I think that they would do a better job with training. That's what we have to think, is that when we train ourselves, when we have access to a better approach, that we can improve our quality. And so I have plenty of problems that I identify with for-profit vendors, but at the end of the day, it's the people in that county that said, sure, we won't spend any money on this, the people in that state. And it's also us as a nation. We said in 1964, the Social Security Act can preclude the use of federal funds. So then it's all going to be local funding in these places. Then the local funding is like a sheriff or a state trying to spend as little as they can. And the people in that state and that community have said it's okay for us to not have our DOH, and it's okay for us to not have our CDC involved. And that, I think, is because of this COVID experience where I'm really starting to pound the that one tent peg in is that the CDC's in there now, so they got to stay. The state DOHs are in there now, they got to stay. And then we can come up with different funding proposals, but we can't do it until and unless we get real evidence-based eyes and ethics constructs into these places.
We have a question about when patients are sent to hospitals outside the correctional system. Could you expand on how dual loyalty might affect physicians who aren't part of the correctional system? And I would add to that, it's a great question, just preconceived notions of physicians, as we talked about earlier, who don't get any training in this area and very little in the way of ethics in this area, what you see happening or what you would recommend.
Yeah, I think that this is an area where you have to provide structured training to your staff as a hospital or a clinic, because it's a pretty wild and woolly set of encounters. Patients come in the ED at least, they may have had a use of force, or they may have had a conflict with the various security staff that are there with them if they're there for an injury. There may be completely different, loud differences of opinion between the security and the security staff and the patient over what the patient needs. And the patient may, report things to the physician or the nurse that they may be reportable incidents, but the doctor or the nurse might not know. Like, what do you do if a doctor learns from a patient that the patient isn't getting their, that all they get in the jail, for instance, is an albuterol inhaler, but they're supposed to get like Flovent every day, and that they don't get it there, and they're there for an asthma attack. Well, what does a doctor do with that knowledge? Except for write on a piece of paper they should get the thing they're supposed to get when they may not get it, And so I think that what is important is I don't think there's anything you could inoculate that doctor or that nurse with that'll solve that problem in that moment. I do think that you have to bring the systems of the hospital to bear on it, to say, who is it that the doctor can send an email to saying, like, yeah, I have a concern about this patient, I don't know what's up. Somebody in the hospital should have the job of communicating with the medical director from the facility, trying to figure out what's happening. And somebody in the hospital should be aggregating this to say, look, we've seen 40 patients in the last year from this place, and like 10 of them had this problem with their not getting medication. So what's up? Like, do you have some QA data you can show us? These, for the patients that get admitted, the hospital seeks reimbursement. For the patients that don't get admitted, it's a loss, or maybe in some big settings, the hospital may get paid a flat rate by the municipality. But either way, there's a real ethical obligation to put together this information and act on it, not just for the individual provider, where I think we do need training, but we need more than that.
I'm going to ask a question that we haven't touched on at all, which has to do with the role of physicians in the lethal injection of prisoners on death row. And there's a small literature written by clinicians who participate in this, sort of recounting their experiences and justifying it, or saying how they sort of ended up finding themselves involved in that. And yet every medical organization, to my knowledge, and this includes EMTs and nursing and pharmacies, and all of these organizations are opposed to the medical profession's involvement in that type of activity. And I was just wondering, I'm looking at your face, so I'm not sure if you could comment on that. Do you have thoughts on that question?
I think, if you're doing that work, you've stopped being a doctor, right? You're because also that work, the way that work has developed in this country, states work hard to keep the identity of those people hidden. They get separate insurance policies. They know that they're not going to be picked up and probably work in a lot of health systems. I just speak for myself personally. I don't believe it's ethical at all, ever. But I will say that it does, if we compare it to solitary confinement, which there are a lot of reasons not to compare it, but they're both examples of systems that harm people, that harm patients, and that we expect, and by we, I mean like jails, prisons, our carceral society expects some amount of healthcare involvement in. And so until and unless we eliminate the practice, we won't ever fix the problem of healthcare staff being platooned into it. We have worked so hard in so many different jurisdictions to think differently or more creatively about how to get mental health staff out of the role of clearing people for solitary confinement. But I think that basically, as long as solitary exists, somebody's going to figure out how to make a doctor or a nurse or a social worker say it's okay for some and not okay for others. And a whole army of lawyers and judges and DOC people isn't going to come out with a different outcome. You're going to have something like that. And that's what I think about capital punishment. I personally don't think a physician or a healthcare person should be part of it, but I also think that we should then eliminate capital punishment.
I have one last question that just came in, and then I think Lydia has our final question of the evening, which is, does the data collection that you urge constitute public health surveillance or research? And this, I'm curious myself, what do you think the protection for incarcerated persons in 45 CFR 46 does for the kinds of data that you would like to and do you think it's what's interfering with that data collection, like it does for pregnant women with new medications, et cetera? Is it too much protection?
I have to say I had the benefit of working at the DOH and H&H. So, we would submit, even though our work, like we probably published 30 or 40 peer-reviewed analyses when I was at the city, we usually would end up, the IRB would usually say, this is quality assurance. You're looking at like, how are you doing things and what are the health outcomes? So often they'd say it wasn't, but we would go through an IRB process. And our IRB had people with lived experience on it. I sit on an IRB now of a nonprofit that does a lot of this kind of work. And I think it's important. One of the things about risk that I think is really tricky in this world is that a lot of interventions or research that I think are important to like talk to people, find out their experiences, they may not elevate the risk over baseline risk, but the risk is not minimal. And that's hard to fit into an IRB context. So I was just in a place 2 weeks ago where people are beaten all the time by correctional staff and sexually abused when they're beaten. And this happens in the medical clinic. And it's a state prison system where I've seen this happen in more than one prison. So it's a systemic problem. Now, if somebody wanted to go there and talk to them about anything, like not related to these beatings, you could propose something that is not above the baseline risk, but the baseline risk is pretty rough, right? And there are plenty of those people that said, one day I said I wanted to go to my mental health encounter, I got beat up, or I got strip searched, or, whatever, this happened or that happened. So I think that it's hard for people some of the constructs we have about level of risk are difficult to apply. Having said that, I think that we need more, and I think Emily Wong has written a lot about this, about how we lose important representation and data when we just avoid this. But then what we need more IRBs with this technical expertise, and we need more commitments to like involve people who are researchers in this world. And I know it's night and day today compared to like 15 years ago, but I think we just need much, much more.
Dr. Venters, this has been so amazing. And I think Barbara and I both just feel it in our guts, how weighty it is. And probably worse, I think, than I imagined. And I'm glad it's better than 15 years ago. The last question that we wanted to ask you has to do with what keeps you going. How do you get up every day and go back, and sort of what gives you hope?
I'll tell you, every time I go into a facility, I have a book like this and I use it to take notes when I talk to people. And, I often have like structured questions about COVID or about solitary confinement or investigating the death. But I will tell you this, something happened. I think the first patient I had who was incarcerated when I was at Monty, that got me so angry about how he was treated in the courts and how it was like bigotry, health-related bigotry, and it got me so fired up. And every time I go into these places, I learn so much from the people there. I'm going to be in a women's prison for all of next week, and I've had a couple of chats on the phone with them, but like interacting with people, learning from them what they're experiencing, and then trying to think with my little like technical skills, which is a very narrow set of skills about medicine and about how I think healthcare should happen and what's going on with them, is really fantastic, and it feels great. Even though these are obviously very dire circumstances and people don't get what they need. But this world is, if I had to characterize it one way, I would say the difference between the truth of what our patients experience and what people say about them is like 180 degrees different. And so as a doctor, as a nurse, as a researcher, you have this incredible opportunity to really engage with people and hear and learn from them, and then try and like lift up that truth, which is suppressed all the time. So it's just so rewarding. I feel really lucky to do it.
Well, thank you so much for your time tonight and for your work. And we wish you all the best as you continue to lead and work with the country's leadership on these issues. We wanted to just take a brief moment to share what our programs are doing respectively. Coming up the next couple of talks, the Columbia Center for Clinical Medical Ethics is hosting our own Harriet Washington to talk specifically about the ethics of student-run clinics, a question that has received a lot of attention from our own medical students. And then in May, we will have Dr. Mark Mercurio, a neonatologist and ethicist at Yale, come and talk about the ethical challenges of care for the critically ill newborn. So join us for those. And I believe Samir posted our listserv email address in the chat. And Barbara, turn it over to you.
I also just wanted to thank Dr. Venners from the bottom of my heart. And I got a real education this evening. I think we all did. And I know that there were some questions that we didn't get to, some really great questions. And I apologize for that. I think we could go on most of the evening. Again, I'll be happy to pass them on if we can. I also wanted to thank Bob Klitzman and Samir Latta from my department for their support in getting this going, and to say that we have two upcoming events. One, March 24th, Thursday at 6:15, Racing with Vaccines, Data, Narratives, and Ethics. That's with Bob Klitzman, Danielle Spencer, and David Kreutner. And then Race and Bioethics, Amplifying Diverse Voices, Harriet Washington, Keisha Ray from the University of Texas, Louis Voigt from Sloan Kettering, and Joanne Suarez from Latinx Bioethics. And that will be a talk on how to increase the number of diverse voices in bioethics, which I think would be sort of in some ways related to our concern about some areas of bioethics that don't get enough attention, and perhaps amplifying those voices might help. So we really appreciate your attention and that you came, and please pass this on to others. The recording will be available.